Greetings, ladies and gentlemen, and welcome to another webinar brought to you by the Malaysian Obstetric Medicine Society. Ladies and gentlemen, for today, I would like to talk about principles of prescribing, especially for cardiac patients during pregnancy. I'd like to declare that I've got no conflict of interest for this talk. Ladies and gentlemen, let's start with 6 different possible scenarios based off real patients that I've encountered in the past. A 32-year-old mother with chronic hypertension was on 150 milligrams of irbesartan. She was planning to conceive and she was told to stop the medications. Ladies and gentlemen, when is the best time to stop an ACE inhibitor or an ARB? Is it months before conception? When will she conceive? Is it very early in the pregnancy? The answer, ladies and gentlemen, first trimester, early pregnancy exposure to ACE inhibitor and ARB is not contraindicated. You don't really want a mother to be unwell before she embarks on the pregnancy. But the correct answer is continue irbesartan until the pregnancy is confirmed at 4, 5, or 6 weeks. And then you can stop. There's got no harm in pregnancy. Patient number 2, a 26-year-old mother with prosthetic mitral valve, was on 4 milligrams of warfarin. She was advised to continue her warfarin throughout the pregnancy because it is deemed safe. Ladies and gentlemen, with regards to anticoagulation among prosthetic valve patients, warfarin seems to be the safest option for the mother. And people believe that based on an old 1987 study, that below 4 milligrams, the risk of fetal harm is not significant. However, ladies and gentlemen, in that old 1987 study, there were only 30 patients in the cohort. In modern medicine, it's all about giving the patients options. Warfarin is not the safest for the baby. And one option that should be discussed is treatment dose of low molecular weight heparin with peak and trough monitoring of anti-10A levels. And that seems to be the way forward. Patient number 3, ladies and gentlemen, a 30-year-old mother with atrial fibrillation was on 75 milligrams of dapiglutide. She was noted to be pregnant and she was converted to 2.5 milligrams daily of fondaparinux. Ladies and gentlemen, although we love our low molecular weight heparin in pregnancy, although we know that biosimilars have got no evidence to be used in pregnancy, we do know that fondaparinux has got significant placental transfer. It has also been transmitted and excreted across the breast milk. It is not the first safest option during pregnancy. And should the dose be 2.5 or should the dose be 5 milligrams? Hence, in this patient, the safest option will be the low molecular weight heparin, which is the enoxaparin. Case number 4, a 42-year-old mother who's got diabetes with a BMI of 40 was diagnosed to have acute coronary syndrome early in the pregnancy at 12 weeks. The managing team advised her to be on aspirin and to be on clopidogrel. Ladies and gentlemen, we know that aspirin is safe in pregnancy, but is dual antiplatelet safe? Is clopidogrel safe? Answer, ladies and gentlemen, yes, clopidogrel is safe in pregnancy. It is not contraindicated. It is only a concern if the patient presents in labor. The recommendation is stop clopidogrel a week before labor is anticipated. But dual antiplatelets are safe. Triple antiplatelets has got no evidence in pregnancy. Patient number 5, a 32-year-old mother presented with heart failure at 12 weeks. She was not given spironolactone since she was pregnant. And most literatures in pregnancy would say spironolactone is contraindicated in pregnancy. Ladies and gentlemen, that is not true. Spironolactone causes feminization of the male fetus. If the fetus is female, spironolactone is not contraindicated. And various studies have showed that spironolactone exposure in utero, although there was a theoretical risk of feminization of the male fetus, has got a dose-dependent effect. And low doses has got minimal harm to the fetus and it's usually safe in among female fetuses. It's not absolutely contraindicated. And finally, patient number 6, a 41-year-old mother with a BMI of 42 has cardiomyopathy and diabetes, was noted to be pregnant at 14 weeks. She tested positive for COVID-19, ladies and gentlemen. If she was not pregnant, if she's got a mild disease, she would have been a good candidate for Paxlovid. She would have been prescribed Paxlovid. But ladies and gentlemen, she was denied this important intervention purely because people thought that it is not safe in pregnancy. However, ladies and gentlemen, we should treat all pregnant mothers the same as a non-pregnant mother. The evidence is clear that Paxlovid is safe in pregnancy. It's not contraindicated. And these 6 examples highlights why we need to be well equipped and knowledgeable about medications, especially among high-risk mothers, especially among cardiac patients. So, ladies and gentlemen, there are 2 golden rules when it comes to prescribing in pregnancy. Number 1, do not ask about the risk of medication, but ask what are the benefits of medications. If you think that medication is going to save a mother's life, she should have that medication. Do not be too fetal-centric in your approach to pregnancy. And point number 2, ladies and gentlemen, there's a huge momentum towards equity for pregnant and breastfeeding mothers, where we should not deny or stigmatize any mother. They should be treated equally. If that medication is important for her own health, then a pregnant mother should also be given the same medication, unless, of course, there's a strong needed reason not to. And most of the time, ladies and gentlemen, a pregnant mother usually needs more, usually needs higher doses, usually needs more frequent doses than a non-pregnant mother. So what is the approach to prescribing in pregnancy? I think point number 1, stop quoting FDA and stop asking the pharmacists. FDA is a risk-based guideline. It does not talk about benefits. I think we as experts must make the clinical decision. Does the benefit outweigh the risk? If yes, prescribe. Principle number 2, do not deny any pregnant mother an essential intervention. We're speaking about equity. We're speaking about mother's health. If she needs it, give it to her. Ask what is the benefit of treatment. Then, is it just a theoretical concern like spironolactone? Or is there documented studies to say it is harmful? If it's documented studies during pregnancy, then yes, use it cautiously. If it's a theoretical risk, look for signs. Most importantly, ladies and gentlemen, not every phase in the pregnancy is important. If the mother is in the first trimester, yes, medication should be used cautiously. But if she's in the second or third trimester, organogenesis would have been completed. The harm to the fetus is negligible. So good to know what is the phase of development of the pregnancy. Secondly, ladies and gentlemen, one of the most important barriers, as good as the blood-brain barrier, is the placental barrier. And even better is the breast milk barrier. So not all medications given to the mother is transmitted at a ratio of 1:1. Most medications with high weight have got negligible transfer. Finally, it's good to appreciate pregnancy adaptations. A mother has got an increase in plasma volume, increase in weight gain, increase in GFR, so she needs more medications, not less. Ask a maternal medicine expert if you're not sure. Usually, a maternal medicine expert should be able to weigh the benefit and risk, give you an evidence-based judgment and guideline that is going to protect you medico-legally and is going to empower the patient and ensure that the pregnant mother gets optimal treatment. Then make a shared decision-making. Do not make a decision on behalf of the patient. Tell her the benefit and risk, counsel and document. But most importantly, be responsible in prescribing. If that medication is important to save a mother's life, it should be given to her. Ladies and gentlemen, let's talk about the phases in human development. There are three phases. One is known as the pre-embryonic phase, the first 17 days of conception. Now, any exposure to any harm, especially toxins or medications, in the pre-embryonic phase will follow a all or none rule. So the mother's exposed will be a miscarriage or a pregnancy loss. There will be no fetal abnormality at this phase. Then comes the embryonic phase. Now, we are extremely concerned about the embryonic phase because this is when most organs develop, the genitalia, the limbs, the heart, the eyes usually develops at the embryonic phase. And usually exposure during this period is what is a concern. And followed by the fetal phase, which is 8 weeks until delivery, where exposure causes less harm. So ladies and gentlemen, early exposure, all or none rule, the baby is viable, the baby is healthy, likely the baby's got no impact. We are only concerned in the embryonic phase and early fetal phase. So this chart beautifully illustrates the important critical period of organogenesis. Ladies and gentlemen, the organ that develops first is the upper limbs, then the lower limbs, then the heart by as early as 6 weeks, and then the palate, the tooth, the eyes, the ears, genitalia by 9 weeks, and finally the central nervous system, which completes its development by 16 weeks. So any exposure during organogenesis in the first 8 weeks and up to 16 weeks is the critical period, ladies and gentlemen. In the pre-embryonic phase, there's no fetal abnormality. Embryonic and fetal phase, yes. But beyond the first trimester, most medications are safe. Organogenesis would have completed, and there's usually no adverse fetal harm, especially with regards to fetal anomaly. Ladies and gentlemen, I'm sure all of us as obstetricians or experts managing pregnant mothers can appreciate various physiological adaptations. In pregnancy, there's going to be reduction in absorption, reduction in bowel motility, increase in gastric pH. There's going to be increase in hepatic flow, hepatic clearance, and enzymatic activities. There's increase in fetal metabolism, uteroplacental flow, but there's an important placental barrier, which is weight dependent on the medication. There's going to be increase in GFR, increase in secretion of medications, increase in resorption, renal clearance. There's going to be increase in ventilation. There's going to be increase in plasma volume. There's going to be increase in coagulation factors. But most importantly, a medication for a pregnant mother has to be a higher dose or a more frequent interval, and that forms the principles of prescribing during pregnancy. Now, what are the pregnancy pharmacokinetics? I think we need to know what is the GI transit time. And the GI transit time during pregnancy is significantly altered, especially during labor, ladies and gentlemen. Number two, we need to adjust medications. It is not often always dependent on the pre-pregnancy weight, but most medications, be it antibiotics, be it anticoagulant, it should be based on the current weight, including chemotherapy during pregnancy. Next, we need to know whether this medication is lipid or protein solubility, because the placental transfer is affected based on the lipid and protein solubility. We need to know the implications of plasma volume to the mother. We need to appreciate whether the medication is cleared by the kidneys, because that's going to be diluted during pregnancy. And medications with large molecular weights does not really transfer through the placenta. It's usually not contraindicated in pregnancy. And these are certain pregnancy pharmacokinetics that we must appreciate, not by asking the pharmacist. It's good to read, it's good to appreciate, it's good to know these medications. Ladies and gentlemen, one important principle about weight is aspirin. Now, for any mother who's got less than 40 kilograms, the recommendation is to use 100 milligrams of aspirin. But if the mother has got more than 40 kilograms, and the recommendation is to use 150 milligrams of aspirin. And this is based on the 1979 Marsalotti study looking into aspirin based on dose, where we use a 2.5 milligrams kg per day based on the booking weight. So, ladies and gentlemen, some medications is weight-based. Some medications is based on the booking weight. Some medications and most medications is based on the current weight. Secondly, we need to appreciate placental transfer. If you give the mother a milligram of medication, it does not mean that 1 milligram is entirely transmitted to the fetus. And one good important example is the steroid transfer of placenta. If you give the mother hydrocortisone, ladies and gentlemen, the placental transfer is only 15%. Prednisolone has got a way lower placental transfer, and only 10 to 12% is transferred. What has got a high placental transfer is methylprednisolone and dexamethasone. And that is why dexamethasone is usually given to the mother to aid fetal lung maturity, because it's got very high placental transfer. If you are to use steroids for mother, use hydrocortisone, use prednisolone, it has got very low placental transfer. It's good to know the medications which are transferred across the placenta. And sometimes, ladies and gentlemen, using the same principle, certain anticoagulation, which is not uncommon and commonly used among cardiac patients, not everything has got a placental transfer. For example, unfractionated heparin is safe. It's got no placental transfer. Heparin has got no placental transfer. Warfarin is contraindicated. Novax is contraindicated. Fondaparinux has been documented to have placental transfer. So the safest anticoagulation during pregnancy is low molecular weight heparin or unfractionated heparin. Having said that, warfarin, although it's transmitted through the placenta, it's got no transfer through the breast milk, and it is safe for breastfeeding mothers. Clopidogrel, ladies and gentlemen, is it safe? Well, this systematic review, which was recently published, to look into the safety of antiplatelet therapy in pregnant mothers. They looked into various gestations. Database search of 5,200 over database, 39 patients. Exposure to clopidogrel in the first trimester, second trimester, and third trimester showed no adverse maternal risk, no adverse fetal risk, and clopidogrel hence is safe to be given at any gestation, except during when the mother is in labor, and so stop the medications 1 week before labor. And ladies and gentlemen, you don't really have to stop aspirin prior to delivery. Aspirin does not cause bleeding. So dual antiplatelets are safe. There's no evidence for triple antiplatelets during pregnancy. Let's move on to antihypertensive medications. Now, what are the options of antihypertensive medications during pregnancy? The common best evidence is beta blockers, which is levodopa, which is everyone's favorite. Calcium channel blockers, nifedipine and amlodipine. Although amlodipine has got no long-term data, it's a calcium channel blocker which is not contraindicated in pregnancy, can be used. And everyone's favorite alpha-2 agonist and decarboxylase inhibitor, methyldopa. Although it is less preferred, it is still a very good, safe antihypertensive medications. So the best evidence is levodopa. Calcium channel blocker nifedipine can be long-acting, which works wonderfully, and methyldopa. Other options, ladies and gentlemen, is hydrochlorothiazide. Now, furosemide is not contraindicated in pregnancy, but it prevents the plasma volume expansion. Sometimes it causes placental hypoperfusion, and sometimes that may cause certain fetal harm. So use the lowest possible dose if needed. And some medications like hydralazine, isosobit monodinitrate are safe, but sometimes it may cause fetal heart rate abnormalities, especially if the mother is hypovolemic. So use it in the lowest possible dose. Some medications that will be used with caution are nitroprusside, clonidine, and nitroglycerine. Ladies and gentlemen, what about ACE inhibitors in pregnancy? It is not contraindicated very early in the pregnancy. 4 weeks, 5 weeks, 6 weeks exposure of ACE inhibitor and ARB is safe. Do not stop it pre-pregnancy. And similarly, it is safe among breastfeeding mothers. You can start captopril and nalapril in postpartum mothers. Breastfeeding is safe. So for mothers who have got nephropathy, mothers who have got heart failure, mothers who have got diabetic, if you are to choose an antihypertensive agent or medication, choose an ACE inhibitor. It is sometimes daily dose. Sometimes it protects the heart, protects the kidney, and controls the blood pressure, especially for preeclampsia mothers. Now, when you discontinue ACE inhibitors, ladies and gentlemen, this wonderful study looked into maternal exposure of ACE inhibitors in the first trimester and followed up all the offsprings. And they showed back in 2011 that early exposure to ACE inhibitors is not associated with fetal harm. So don't stop preconception. It is safe to be stopped early in the pregnancy, 4 to 6 weeks, once the pregnancy is confirmed or once the urine pregnancy test is positive. So ladies and gentlemen, how about beta blockers? There are many types of beta blockers. Traditionally, we used to love our propranolol and metoprolol, but now we know that a modern beta blocker, bisoprolol, which is more specific to the heart rate, does not drop the blood pressure as much, is preferred. Its daily dose and should be the first preference of beta blockers to be used in pregnancy, especially if you're going to control the heart rate, not to control the blood pressure. Then propranolol, although sometimes you can use TDS dosing in pregnancy, it is associated with risk of fetal growth restriction, and such patients need fetal growth monitoring. The second option and third option is metoprolol. You can actually use the TDS dosing and the good old atenolol. Although it's daily dosing, sometimes the frequency needs to be increased during pregnancy because of the increase in GFR. So ladies and gentlemen, the first option is bisoprolol. If you're going to use propranolol, you can use a more frequent interval as compared to a non-pregnant mother. Heart failure medications. The best evidence is for metoprolol. Carvedilol is safe. Furosemide is safe, but use the lowest possible dose. Dopamine, dobutamine, norepinephrine is safe. Other options for furosemide, we spoke about safety. Hydrochlorothiazide is not contraindicated. But be cautious, it's not contraindicated, but you can use cautiously with hydralazine and isosorbate dinitrate. Although it's a potent vasodilator, the blood pressure may drop. You may have fetal heart rate abnormalities, but it is not contraindicated, ladies and gentlemen. Spironolactone is not absolutely contraindicated. The only concern is feminization of the male fetus. A good obstetrician, or by using a non-invasive test, you can confirm the fetal gender as early as 11 to 12 weeks. Hence, if it's a female fetus, if the mother's got heart failure, please give her spironolactone. And even more importantly, ladies and gentlemen, the association has been not based on evidence base, has been on theoretical. It has got a dose-dependent effect. And the current literature shows that a daily dose of less than 200 milligrams per day exposure to the mother has not been proven to cause any harm to the fetus. It can be given and is not contraindicated during pregnancy. Antiarrhythmic medications. The best evidence is for adenosine, followed by digoxin, bisoprolol, propranolol, metoprolol, and lidocaine. Other antiarrhythmic medications, verapamil is safe, not contraindicated in pregnancy. Diltiazem, procainamide, sotalol, flecainide, and propafenol. Ladies and gentlemen, flecainide has got a good placental transfer. If you're going to treat SVT for the baby, it is usually given to the mother. We have to monitor the mother's heart rate and the baby's heart rate. And among all the medications, one medication has got a good placental transfer, better than digoxin is flecainide. Use cautiously, although not contraindicated, amiodarone is usually used as a second line It is not contraindicated. It causes sometimes fetal hypothyroidism. Hence, if the mother's got amiodarone exposure, talk to the pediatricians, look for goiter and check the TSH, which is actually universally performed and checked for every mother. Amiodarone is not absolutely contraindicated indicated in pregnancy. For patients with pulmonary hypertension, the best evidence is to use elioprost. Sildenafil is safe. Epoprostenol is not contraindicated. Only use cautiously. But ladies and gentlemen, if the medication is extremely beneficial, if it's going to save a life and improve her outcomes, it is never actually contraindicated in pregnancy. Let's revisit the 5 milligram warfarin rule. Ladies and gentlemen, it's not uncommon for everyone to perceive that warfarin has got a dose-dependent effect, and that if someone is on less than 5 milligrams of warfarin, the risk of fetal embryopathy is between 2 to 5%. And that is based on this very old 1999 paper by Nicole Vitala. However, ladies and gentlemen, in this paper, those with less than 5 milligrams, they only had 28 fetuses. Those with more than 5 milligrams, they had 3 fetuses. And based on a total of 31 patients, almost 25 years ago, they concluded that 5 milligrams of warfarin is safe. Ladies and gentlemen, warfarin has got two effects. One, first trimester exposure has got a dose-dependent effect and causes fetal warfarin embryopathy, nasal hypoplasia, short, long proximal bones. But after 12 weeks, ladies and gentlemen, it is not about warfarin embryopathy, but it may cause fetal bleeding, fetal intracranial hemorrhage, which is not dose-dependent, and the warfarin-associated pregnancy loss can be as high as 30%, ladies and gentlemen. So I think we should move away from this old 5 milligram study. It's good to counsel patients, but it is only for warfarin embryopathy. Fetal loss is not dose-dependent. So what are the options for patients on warfarin, ladies and gentlemen? Option number one, the traditional option, is to use warfarin from 6 to 36 weeks if you use the old less than 5 milligram rule. It's got a lowest maternal mortality and thrombosis risk of 0.9%. It's best for patients who have risk, who have got a prior history of valve thrombosis, who's got a dual valve, who's got an old valve, or who's got atrial fibrillation. The dose is below 5 milligrams. The risk of fetal embryopathy is 2 to 5%. But the risk of fetal loss can be as high as 30%. The patient needs a very strict, tight control of INR, especially if there's nausea, vomiting, hyperemesis, and bleeding. And she presents in labor being over-warfarinized. The recommendation is to do a cesarean section. At 36 to 37 weeks, you can convert to low molecular weight heparin. The older studies suggest unfractionated heparin, but the cause of bleeding, ladies and gentlemen, is not warfarin. It's not low molecular weight heparin. It's actually unfractionated heparin. So use this cautiously. And then when to start warfarin, although most guidelines say day 5, it takes 3 days to achieve a plasma steady state. You can actually start warfarin on day 2, day 3, but most guidelines say day 5. And breastfeeding is safe among patients with warfarin. But it's good to know what medications that may react with warfarin, because this may trigger a bleed, usually NSAIDs. Tramadol does have a cross reaction with warfarin. Certain antibiotics can cause a patient to bleed. Some patients with aspirin may have a dual effect, a synergistic effect between warfarin and aspirin, and that can also trigger and predispose a patient to bleed. It's not uncommon to give PPI for pregnant mothers, and omeprazole may react with warfarin and cause bleed. And of course, although rarely we'll have a pregnant mother on vitamin E, may also affect and react with warfarin. So good to know medications, good to know dose, good to know other medications that a patient is taking, because some may react. It's important to counsel our patients. Now, ladies and gentlemen, now based on this British Society Hematology guidelines on anticoagulation, just published a year ago, March 2023. Modern way, a move away from warfarin, is a treatment dose of low molecular weight heparin, a total dose of 2.5 milligrams per kg per day. I give an example, ladies and gentlemen. If the patient is not pregnant, and if you are to use enoxaparin, then the total dose per day will be 2 milligrams per kg per day, or 1 milligram per kg per day BD dosing. So if a pregnant mother is 60 kilograms, she will need 60 milligrams BD, 120 milligrams daily. If she's 60 milligrams and she's pregnant, then she needs 2.5 total dose. So that'll be 60 times 2.5. So her total dose will not be 120, but it'll be 150 milligrams divided by 2. So the starting dose of low molecular weight heparin in a 60 kilo patient will be 75 milligrams BD. You don't have a 75 milligrams, so you can give her 80 milligrams of enoxaparin and check her peak and trough anti-tannin levels. Based on our own study in where we used to work, the total dose that a patient needs is 1.4 milligrams per kg BD twice a day for patients on low molecular weight heparin, which works out similar to the British Society guidelines of 2.5 milligrams total dose. So ladies and gentlemen, if the patient is 60 kilograms, don't start her on 60 milligrams BD, but start her on 1.4 times 60. So she'll actually need 80 milligrams BD and a check anti-tannin levels peak and trough. So how do you manage low molecular weight heparin during pregnancy? Use a formula of 2.5 milligrams per kg per day, not BD, per day low molecular weight heparin. The risk of thrombosis is highest in the first trimester because of nausea, vomiting, and because you're about to bridge anticoagulation. So be cautious in the first trimester. Weekly, peak and trough anti-tannin levels. The maternal mortality may be as high as 2.9%. It is lower among patients with warfarin, but it's got a highest risk of live births. The antenatal management is to check peak anti-tannin levels, and the peak anti-tannin levels of 3 to 4 hours post-injection should be in the range of between 1 to 1.4 international units per mil. In low-risk patients, you can achieve a peak of 0.8 to 1.2. And the trough, ladies and gentlemen, the trough, which is what is essential to prevent a thrombosis, should be above 0.6, which should be taken just before injecting a BD dose of low molecular weight heparin. And then the recommendations also recommend, apart from warfarin, is to start these patients on low dose of aspirin, 75 milligrams if the patient has got no preeclampsia risk. The patient has got a preeclampsia risk, then add on the usual aspirin dose of 150 milligrams. And we now know, although aspirin may have a synergistic effect, the risk of bleeding is not significantly increased if you use this in combination. Some other medications for cardiologists. Oxytocin, a commonly used medication, has got maternal harm. It may cause hypotension. It may cause tachycardia. So ladies and gentlemen, we have moved away from the traditional 10 international units of oxytocin. We have moved away from 5 international units of oxytocin. The current studies say that it's been used 10 purely because the one vial has got 10. The recommendation is to use 3 international units of oxytocin, and that causes good tone, prevents PPH, minimizes hypotension, and prevents tachycardia. So the lowest oxytocin dose is the way forward. You can give a bolus of 3, followed by an infusion of 10 IU per hour, or you can repeat another bolus of 3 international units, not 10. Ladies and gentlemen, one other aspect that I believe is the future and paradigm shift is the safety and the use of statins in pregnancy. And this wonderful paper in the TOG, which was published also in 2023, talks about management of hyperlipidemia and severe hyper-TG during pregnancy. And I believe in the next few years, we will be managing hyperlipidemia in pregnancy because there's growing evidence that statins are safe. Ladies and gentlemen, if you take a look at plasma cholesterol and TG levels, it significantly increases in pregnancy. As early as 12 weeks, your total cholesterol goes up, and that continues to rise throughout the pregnancy. It's a peak of 36 and 40 weeks, and then comes down after delivery, postpartum, to the normal state. And this condition, these weeks of high cholesterol and TG, usually causes significant metabolic harm with long-term implications to the mother. And now we also know, ladies and gentlemen, that various statins are safe to be used in pregnancy, especially omega-3 acid esters, cholestyramine, fibrates, fenofibrates. Statins are safe and not contraindicated in pregnancy. And I'm sure everyone also knows that I have used pravastatin in many occasions to prevent preeclampsia. And study shows that 20 to 40 milligrams of pravastatin is safe, is not contraindicated in pregnancy, is essential in preventing preeclampsia. And how pravastatin works is that it increases VEGF, increases PLGF, it decreases S-fleet, which is essential in the pathogenesis of preeclampsia. It inhibits platelet addition. It decreases thrombosis and inflammation. It increases nitric oxide. And all this reduces vasoconstriction, improves endothelial dysfunction, and prevents preeclampsia. So pravastatin is safe. Statin is the new kid in the block that is going to be used, I believe, to treat hyperlipidemia during pregnancy. So drugs that are perceived to be contraindicated, which I think is no longer contraindicated. Warfarin, ladies and gentlemen, all studies showed dose-dependent, but the risk of embryopathy may be dose-dependent, but the risk of fetal loss of 30% is not dependent on the dose. People often speak about ACE and ARB. It is safe early in the pregnancy. It is very safe among breastfeeding mothers. It can be initiated during pregnancy. Spironolactone is only a concern if it's a male fetus. It's got a dose-dependent effect. Anything below 200 milligrams is safe. It is not contraindicated during pregnancy. Amiodarone, use it cautiously. It's associated with fetal hypothyroidism, but it should not be withheld if you think that it's important to save a mother's lives. And ladies and gentlemen, there's growing evidence that statins prevents preeclampsia. Statins are safe and not contraindicated. Now, the prescribing checklist, ladies and gentlemen, I think this forms the gist of my talk today. I think before we prescribe, ask what is the benefit of treatment. I think we should understand the risk. Is it theoretical? Is it risky because there's been no studies ever done in pregnancy? Or is the harm published and documented? Is it a new study? Is it a randomized study? Appreciate placental physiology, because we need to know whether it is protein soluble, lipid soluble, or is it of high molecular weight. I think the gestation is important. If it's organogenesis, be concerned. If organogenesis has been completed, then it's less of a concern. Alternatively, talk about alternatives. But the principle is use the lowest possible dose. But ladies and gentlemen, not all medication has got a one-to-one placental transfer, because whatever medications you use, the amount of fetal harm or fetal dose depends on the placental transfer. If unsure, ask and seek a maternal medicine expert who will be able to guide and give you an evidence-based counseling. As obstetricians, as physicians, be responsible in prescribing. Make a decision and should be balanced between the benefits and the risk, not just the risk, not just the fetus, but think of the mother. And it should be a shared decision-making with the patient with an evidence-based, neutral, unguided, unpressured counseling. So to summarize my talk, ladies and gentlemen, for allied healthcare professionals outside there, please do not stigmatize pregnant and breastfeeding mothers. Medications are safe. Please check with the experts, not just a specialist, not just a physician, not just an obstetrician, but a maternal medicine specialist, not FDA, not Google. Good sites are best use of medications in pregnancy called BUMS, or the UK Teratogenicity Information called UKTRS. That's an evidence-based way to prescribe medications. But more importantly, ladies and gentlemen, if unsure, check. Never stop a medication without consulting a pregnancy expert. For obstetricians outside there, own your patients. You should decide, and you are the experts when it comes to prescribing in pregnancy. Be knowledgeable, be responsible in prescribing during pregnancy. Don't just do a detailed scan and say the baby is fine and safe, but advise, guide, protect, counsel patients. As obstetricians, I think you are the obstetric guardian of the fetus, but of the mother as a whole. And I think we need to empower patients and guide non-obstetricians, because prescribing should be responsible, prescribing should be safe. For physicians and cardiologists, ask the benefits, not the risk. If you're unsure, discuss with a maternal medicine expert who may be able to advise you about medications. Not a maternal fetal medicine expert, a maternal medicine expert. But more importantly, treat every pregnant mother the same as a non-pregnant mother, unless there's a strong reason not to, because the life of a pregnant mother is far more precious. With that, ladies and gentlemen, here's a good guide. We're going to talk about best use of medications in pregnancy. This paper was published in 2019. It's called The Use of Medications for Cardiovascular Diseases During Pregnancy. It's a good read. And with that, I'd like to thank you so much for your attention. If you need more information, kindly visit us at www.obstetricmedicine.my. And thank you so much for your kind attention.